Welcome to our channel. In this video, we discuss calcaneal fractures, which involve the heel bone. These fractures are relatively uncommon, accounting for no more than 2% of all fractures, and are mostly high-energy fractures, meaning they arise from trauma such as car accidents or falls from a height. The diagnosis is simple. An X-ray is sufficient, but above all, a CT scan with 3D reconstruction is necessary, which is much more useful in evaluating the fracture than an exam such as an MRI. Ultrasound is an even less useful exam and is therefore not required. When we talk about a fracture, we use criteria to describe it. These criteria, reduced to the essential, are 1. The possibility that the fracture is undisplaced or displaced, that is, whether the fragments are or are not aligned with each other. 2. Whether the fracture is complete or incomplete, that is, whether or not it involves the entire thickness of the bone. 3. Whether or not the fracture involves the joint. Therefore, we will speak of an intra-articular or extra-articular fracture. 4. There is then an additional possibility. The fracture can be open or closed. An open fracture is one in which the skin has also been damaged, causing the bone to come into contact with the external environment, such as soil, mud, or water. This obviously represents a very unfavorable prognostic factor because it can lead to the formation of a chronic bone infection, which we call osteomyelitis. The need for fracture surgery is more likely the more complete, displaced, and joint involved the fracture is. As mentioned above, an open fracture is a poor prognosis for the development of infection, which may therefore require further surgery in the future due to bone infection. Whether or not to operate immediately depends largely on the swelling of the soft tissues. When the patient arrives with a severely swollen foot, it's best to wait a few days for the tissues to deflate and allow for a greater safety margin to be achieved. This will avoid damage to soft tissues such as the skin, tendons, muscles, and ligaments. If the patient is taking an anticoagulant, it will be discontinued. Instead, we will use low molecular weight heparin. Patients taking aspirin for heart problems can safely continue taking it. This drug does not need to be discontinued. When we talk about intervention, we talk about reduction and fixation. These two terms therefore indicate the possibility of realigning the bone fragments and stabilizing them with a plate and metal screws. For an additional degree of certainty regarding the proper reduction and therefore alignment of the bone fragments, we use an X-ray device that allows us to monitor step by step the quality of the reduction achieved during the procedure. The surgical access can be a minimally invasive surgical access, but generally we find ourselves with complex fractures, and therefore I prefer to use a more extensive surgical access, like the one shown in the photograph. This is a curved surgical access that allows us to have full exposure of the bone fragments, and in this way, we can be sure of having a much more accurate and precise reduction. To stabilize calcaneal fractures, we need to use sets that include many tools for preparing and measuring the screws. The screws in these sets come in various shapes and sizes to ensure the best possible selection. The set obviously comes with the plates, and the plates themselves can vary in shape and size. These are particularly suited for a minimally invasive technique, while for more complex fractures, those with multiple fragments, plates with this type of geometry, are preferred. These plates are angularly stable, also called locking plates, meaning they are threaded inside. The drill guide is screwed into this thread, preparing the seat for the screws. Once inserted into the hole, they will fit extremely securely inside the plate. The first part of the surgery involves identifying and reducing the subtalar joint, which is the most commonly affected area and, if not treated properly, puts patients at greater risk of developing symptomatic osteoarthritis in the future. Once a good reduction is achieved, 1 or 2 compression screws are inserted. After preparing the screw slots with this tool, the exact length of the screw is measured to prevent the tip from protruding beyond the bone. We then insert the screw, which is placed under compression, to bring the bone fragments closer together, thus allowing the fragments to heal. Once this first part of the procedure is complete, we will finally use the angular stability plates. Ideally, these plates will provide significantly greater stability than compression screws alone, thus allowing us to restore the anatomy of the calcaneus, which is very often compromised in these fractures. These angular stability plates therefore require the insertion of various screws. These screws will allow for the best possible anchoring of the plate to the bone. Every time we prepare the screw hole, we use this simple measuring tool to allow us to use the most appropriately sized screw possible. We then insert the screw, which fits inside the plate, creating a very stable construct. This same procedure is repeated several times to anchor the plate in multiple points on the bone. In the end, we will therefore have 1 or 2 free compression screws at the joint level and the plate with other screws that will further stabilize the fracture, allowing it to heal. After surgery, you will need to use a boot-shaped brace for the next 4 to 6 weeks. With this brace, you will only be able to put weight on the ground lightly, so the physiotherapist will teach you how to walk and place your weight on the ground correctly. Until you can put your full weight on the ground, you will need to take prophylactic low molecular weight heparin to reduce the risk of thrombosis. To avoid swelling, it is very important to keep your foot raised. The dressing is generally changed once a week, and it's very important to avoid smoking to help promote healing. We know that heavy smokers are at risk for developing problems with skin healing and fracture healing. In the following months, you will definitely need to undergo physiotherapy for lymphatic drainage, joint mobilization, and to gradually retrain yourself to put all your weight on the ground. Complications of surgery include problems with wound healing. In this case, as I mentioned before, there are groups at risk, such as smokers, but we must not forget diabetics or dialysis patients. In some cases, this problem with wound healing is so severe that a negative pressure system is required. This involves a pump that suctions the wound 24 hours a day and is essentially a small device you carry with you in a purse that serves to stimulate healing. Unfortunately, sometimes this negative pressure system is not sufficient, and in more severe cases, plastic surgery must be considered. Infection, however unlikely, cannot be ruled out. Naturally, infection is more likely in cases of open fractures. As we mentioned at the beginning, if infection occurs, you will definitely need to take an antibiotic orally or intravenously. The infected wound or bone may require further surgical cleaning in the operating room. Sometimes, between cleaning procedures, the negative pressure pump system will need to be used again to stimulate healing. Deep vein thrombosis. To try to reduce the risk of blood clots in the leg veins, once daily injections of low molecular weight heparin are used. The injection is painless and is certainly more effective, especially considering the risk of injury, than oral anticoagulants. Osteoarthritis is the most common complication. In particular, involvement of the subtalar joint surface leads to cartilage damage, which in the months or years that follow can be treated initially with cortisone injections, hyaluronic acid injections, or plasma injections known as PRP. In more advanced cases, especially those less responsive to conservative treatment, another procedure called arthrodesis, or fusion of the joint between the talus and calcaneus, is possible. To summarize the treatment of calcaneal fractures, in a few words, I would say that it is a challenging issue for both the patient and the surgeon. For the surgeon in particular, the complexity of fractures with multiple bone fragments, and the fact that the fracture almost always involves the joint. For the patient, these fractures require several months of physiotherapy, always keeping in mind the risk that, due to joint involvement, a condition of arthrosis may develop at the level of the subtalar joint, which it may also require subsequent surgery for arthrodesis, which means blocking the joint. On the other hand, these are often fractures that cannot be left to heal on their own. In fact, the fracture often tends to deform the bone and involve the joint in such a way that the only option to consider is surgery. Therefore, the advice is always to carefully discuss with your surgeon the type of surgery, the type of complications, and what results to expect post-operatively. If you think this video was helpful, or if you think it could be useful to someone else, please like and subscribe to the channel. Thank you.